interesting and the most, what do you call this? Well, most interesting part in anatomy, because we already relate anything to the heart. Now, I just like to emphasize to you guys that when you have emotions, after the end of the lecture, as part of my objectives, at the end of this lecture, it will actually tell you that the heart has nothing to do with how you feel. Huh? It's a pumping organ. It is one of the most important organs in our body, but it has nothing to do with your emotions. I hope you can actually settle that issue after this lecture. Everything is up here. Ha? Kana imong mga emotions, affections, heart tayo, kita kong heart yung mata. You should always you have to destroy that myth. Okay? The heart has nothing to do with it. But again, the point na is you will know how beautiful the organ is after this particular lecture. And you will be surprised. Not a single computer, not a machine, not an invention by either of these geniuses in the IT world right now can replace our heart. Nindot hindi siya pagkanatin. Kaya ikag unbelievable. How it was made, how it was served for its purpose, and how it is adjusted to our daily lives. Take note again, the heart does not rest. Once you were born, or once we were born, it pumps now. Okay? It pumps until the day of our last breath. No batteries needed, no charging needed, no power banks needed. What's pa? No solar panel, wala yun. Diba? So now you can start to okay, it's not just as simple as a 4-chamber organ. I know you've been doing dissections with reptiles, with mammals. Okay, but before we proceed, we need to acknowledge the pioneers. I always am very fond of you guys, especially, because when you ask history, okay? But from what's happening around social media, we should know and respect and earn the pioneers who started it. Curiosity, maganda sila. And one of the most studied organ way back in the 15th century was the heart. Intrigue is the heart. Okay, what keeps us alive? And then when they open animals, of course they started with animals. Some of them went to the extent of digging up cadavers. Okay, exhumed the cadavers, they were not straight dead. Getting cadavers and studied them, of course, post-mortem. Who is this? Of course, it's Harney. But this is Gallen. Okay, if you heard the word Gallen, he was the first one who has this curiosity of studying the heart. Okay, but it was so simple because he was very limited in his resources. Because you need to ask permission from the political authorities, a lot of religious interference. The religion then was so strong that if you open up the human body, that is such a religious issue. Okay? Well, again, so he was doing it secretly. Of course, he studied first with mammals, but later with humans. So limited the resources, but he came up with the first manuscript of the heart. Then, of course, it started again later on by this British anatomist by the name of Professor William Harvey, who actually dedicated his life in studying the heart. In fact, there is still a book named after him, after 19th century. Detailed book, and it's one of the most bestsellers of Harvey's Heart. It's important like that thick. Okay? So of course, we are not using this for particular, but if you're really interested in it. This was the first manuscript he published. okay, way back then, to about the human heart. Okay, this time it's about the human heart. So, and these were his tools then. Of course, I don't have pictures or my picture camera before. So this was his obsolete gamit. He was using kitchen knives, bone saws, carpenter to open up the sternum, everything. And of course, he was using pigs. Pigs, maging usually common. Why pigs? Are you surprised by why pigs? In fact, there is the latest news now. First operation, successful heart transplant using the pig's heart. Okay. Why pig? In fact, when we do our, when I had my workshop on laparoscopic in veterans in Manila, way back then, we were using pigs for the gallbladder. Why pigs? Okay. Very good. Because the anatomy of the pig is more or less similar to humans. So the next question now, challenging to Darwin, is where do we come from? The heart, similar to humans. The gallbladder, including the ducts, the extrahepatic ducts, the size of the gallbladder, similar to the pig. Intestines, the one that you are fondly eating, similar to humans. So now, asa naman yung ikaw? Vertical. Okay? And do not, and that's the reason why, guys, our Muslim friends do not eat pigs. Because they feel like they're just eating humans. You know that one? Okay. I'm just joking. Dili na related sa Karoon na sa iba ako, similar rin ako. They can actually attest that one or defend, and that's why I don't eat pigs, because it's like I'm eating humans. Because similar with if you notice, it's the, well, besides, of course, I would agree that we have more mammals that are similar to humans, but it's the accessibility na saan, right? If someone is going to tell me that the tiger is more similar to humans, then how can you get a tiger left and right? It's always accessibility. Domestic man siya. Okay, so usa sa factor. I don't think it's actually because it's 90% related to humans. So anyway, that is Harvey. Now, tanong mo muna. When is that, guys? 14th of February. You always send a card or emoji or even throw it up yourself. Again, an action symbol. Okay? Again, because of emotions, but again, I would like to reiterate that for the next time you are now in day, sa month of medicine, next February, if namin mga crush ka na, then you want to send a drawing, you want to send a card, next year, make sure that you have to send that one. Because that is no way it looks like the heart. But it has been there ever since because sa'yo, marahin mo, mag-anak-anak pa. Next time, mag-heart mo, how would you do a simple like? You are now in medicine. You have to make sure that that is no way dili na siya heart. There is no chamber pagyo. Okay? It's so easy magod. You are not layman anymore. So from the next time pa daw mo kanina yung drawing na, and I want it in detail. To include the vessels, to include the auricle, and to include the sending portion. Now take note, guys, when you say the heart, when you hear the word the heart, you cannot just separate these guys. Hindi lang nakaset kanila. Okay? It has to include the take-off and in one great vessels. So that's how our really heart looks like. And as a whole, you cannot just remove them because you cannot separate them. You know why? You cannot separate the pulmonary trunk from the right ventricle because it is continuous. You cannot separate the pulmonary veins from the left atrium because it is actually continuous. You cannot separate them, and at the same time, the ascending aorta, you cannot separate them from the left ventricle because they are continuous. There's a big difference. You cannot separate them. And you will later find out what makes it continuous. Okay? Second, let's officially go to the compound. Okay, so I think narrated the objectives after the end of the lecture to dismiss the mga Buana and the functions. We already know the functions of the heart. If you ask a guy, if you ask even your niece or nephew or your children, makatupag mo na. What's the purpose heart? Diba? Some of them, of course, I'm not saying all of them, but some of them, majority of them will answer provides blood to the body. Period. That's the simplest term that you can actually give. We also note that there are 4 chambers. Now take note as I go along with the lecture. I cannot tell you the whole term, so I'm just going to say what? RA, RV, LA, LV. Huh? I don't know kung they has all words, ha? So RA, RV, automatic lang siya. So actually, these are acceptable terms. So when you say RV, LA, understandable lang siya. As long as you are talking about the heart. Okay? Dili LA, California lang. Lahay na sana. Okay, so LA heart. Okay, now take note again as a pure and simple logic of cyto. We already know that blood, as a review lang natin, although this is physiology, but before we even talk about the details about the heart, we should know where blood enters and leaves. Okay? From above, from the head part, above, the head and neck part, passes to the SVC. Anything below the chest, body, pelvis goes to the IVC. Okay? And everything goes to where? RA. The main reason why I'm telling you this, because we are going to go into the details, grossly, each chamber. Each chamber has its own peculiar structures that you need to identify. So, dahan mo sabihin sa dihan. Okay? Structures. So, meaning, if I'm going to tell you, SVC, IVC enters the RA, so you're going to expect to see openings in your RA. Opening. You can see a hole there in your RA coming from the SVC and IVC. Actually, there are 3 holes there. Okay, so RA. Then, after that, it passes through your atrioventricular valve. Specifically, what? Sorry, I'm just revealing you guys naman is pre-med ninyo. Specifically, what is the valve on the right? Google. What do you call the valve there? Tricuspid, okay? Or tricuspid valve. What do you mean when you hear the word tricuspid? Tricuspid. It's cusp, not cusp. Cusp. So meaning you're going to see 3 cusps there sa imong atrioventricular valve. Now take note when I say atrioventricular, it applies to both right and left. Atrioventricular. So, tricuspid enters the RV. From the RV, nawa na, ha? Pulmonary trunk. Okay? Pulmonary trunk goes to the lungs via the right pulmonary artery, left pulmonary artery. Now take note again, misnomer. Blood towards the lungs is supposed to be vein, right? It's bali siya. So do not confuse between the pulmonary and the rest of the vessels. So pulmonary trunk, PA, PV, PA right, PA left, respective lungs. Gets oxygenated, then goes back to the heart via PVs. And there are 4 of them. 2 superior, 2 inferior. Both coming from each lung. These are already oxygenated. Diba? But again, the soldiers have fee. So, 4 PVs, 2 superior, 2 inferior goes to the LA. Gets what? LA, atrium. So now, you're going to expect to see 4 holes in your LA. Before we even go to the details of each chamber. Of course, these are just some. Then enters the left AV valve, known as your bicuspid or mitral valve. Bicuspid, meaning duhara cusp. Okay? So you're going to see this later on. Then enters the LV. After the LV, goes to aorta. Of course, there are parts of the aorta pa, ascending, arc, descending. Okay? But part lang sa heart, we're going to talk about only the ascending. Forget about the arc. Okay? Ascending that's for the great vessels of the body. Okay, now again, placement sa heart, you can see the close affinity with the great vessels there in its location and position. Looking at it from the sagittal section, from the diaphragm, you can see actually probably devoid of vital organs surrounding the heart. Unlike the other organs of the human body where there are contiguous structures which are actually directly related to that particular organ. If you look at the heart, it's practically devoid of a direct organ from the front, anterior, and also devoid of very important structures posteriorly. So it has its own space lang there to pump. Diba? Free din siya, free. Because again, unlike the lungs, you can stop breathing for a while. Pwede man ninyo i-relax ang lungs, but not the heart. So it needs a space to keep on pumping. Even though while resting, it still pumps. Diba? Okay, cardiac cycle, these are, you heard who knows how to take BP here? Not the automatic. What I challenge. I know it's not digital. When you are students, even though it's available and it's more convenient, but you need to know, in fact, we don't teach you in your second year if you reach second year. If you reach second year, when we teach you PT, we don't bring you, okay, bring your digital sphygmometers. You always bring your stethoscope. Okay? Because there is no, you cannot replace the listening, the auscultation, compared to digital. You do not know weak ang battery, then you will have the short blood or low blood pressure there all of a sudden. Okay? Because it's dependable on battery and some of the technology. And where it's made from, okay, so you cannot hide the fact that you have to auscultate or listen. Take note that you heard systole, you heard diastole. Now, when you hear the word systole, it's more on ejection or contraction. Diastole is resting or the feeling state. Feeling up, okay? So rest na siya. But take note, guys, that the cardiac cycle, it's not RA blood goes to the RV, then few seconds goes to the LA, goes to the LV. The wonder of the heart, everything from this whole cardiac cycle, it's simultaneous. Try to imagine that. Blood from the RA, RV, goes to the lungs, LA, LV, ejected, meaning to the system. This is all simultaneous. Split second right difference. Imagine na nagulat. Are you imagining? Meaning, we were made to believe when we were young, okay, blood goes to the RA, now sa RV. Diba? We were narrating that one. But everything is actually together. Hindi mo na siya stop. So, that's how fast, even with a blink of an eye, meaning blood zone, lungs, body. That fast. Because you cannot put a resting stage in between. If mo rest ka, arrest ka. Right? Mo-arrest ka. You cannot say, okay, can you rest for 5 seconds? Oh, rest na. You cannot put the heart to a standstill. So everything is synchronous from the pumping of the chambers to the filling up of the other chambers and going to the lungs and vice versa. That's the one level. Now take note that diastole is this. Okay, so when the heart fills up, it elongates. But when the heart goes into systole or contracts, it shortens. Well, I'm talking about the cardiac muscle. Now, the cardiac muscle, mostly in the myocardium, is not shaped as cell, it's not shaped like histology. It's not shaped as an ordinary cell. Yan mo shorten siya and then longer, mo lengthen. It's not. It's helical. So the shape of the cardiac muscle is helical. So when it shortens, it turns. And when it rests, goes back. Okay? So shorten, one siya shorten, then elongates. So when it rests, then tense, diastole, then shortens if it contracts. So dili na siya contract as in contract na shorten. Now, take note again that we are all meant to be, when you listen to the heart, or auscultate the heart, it's something very common, which is the love-dub sound, di ba? Alam mo na siya. Correct? Love-dub. When you hear the word love, blood from the atrium goes to the ventricles. That's the first sound that you hear. Love. That's it. Meaning blood, atrium, ventricle. Both. We're not talking right side, left side. Both na siya. Again, as I mentioned, it's synchronous. Then we hear the word dub. The love-dub. When it expels the blood. Either expelling the blood from the RV to the lungs or from the LV to the systemic circulation. Now, especially 3 years from now, I've been seeing a lot of clerks, especially first day of clerkship, wearing their white, shiny uniforms, putting stethoscopes around their neck. Then, paminawon ni most of the heart sounds, they do not even know where to place properly the diaphragm of the stethoscope. Puro marating ko po, puro lang yan. Matuan to all po stethoscope. And that's the reason why the same with the lungs. Supposedly, if I was the one who lectured the lungs, there is supposed to be a technique in when you listen to the lungs. Dili na siya putang-bultang inyong stethoscope. Yeah, there is supposed to be, because you're not supposed to miss the lobes. Each lobe you have to hear, you're supposed to hear the air coming from the trachea and your bronchus. So when you auscultate the lungs, you should start here. You should know, you should hear the trachea. So, dili na ditso lang na rin. Okay? Then you have to hear the bronchus before you go to the lungs. So that's the technique of when you hear. The same with the heart. The heart is more specific because again, we go back to surface anatomy. This time, we're going to use costal cartilages, not the spaces. As your guide, where are these structures located based on surface anatomy? Okay? Even though why are you teaching this auscultation at some surface anatomy still belongs to me. You cannot start proceeding paminaw, taglab-dab if you don't know where to place your stethoscope and what structure of the heart are you listening. You're supposed to listen to two things. The closing of the valve and the filling of the blood. Okay? The filling of the blood and the closing of the valves. Now, there are two types of valves. You have the AV, which you're supposed to listen. You have also the SL, which are the semi-lunar valves. Lahit sa siya. Okay. Cycle, glue, and oxygenator. This is just a review, guys. Before we go to the major topics. Okay, it's just a review. Feeling, atrial contraction, that is diastole, systole. Actually, diastole comes first before systole. But when you take your blood pressure, you always say the systole first, right? Below is the diastole. But when you hear the lambda sound, auscultation, before you even inflate your mercury there, or your sphygmon, actually the first sound that you hear is your diastole. Ano siya, lab. This is the lab. Okay? But when you write it down, it's supposed to be the systole first. Okay? or reflex anyway. Okay, layers. We already mentioned this one a little bit on the topic on the pericardium. Endo, okay? Take note, key points. Endocardium, the innermost layer, which is the shiniest there. It actually continues and covers the valves. So yung layer actually all the way continue sa valves. Both right and left. Of course, the myocardium, take note, the description of the cardiac muscle is helical. It's not just an ordinary cardiac muscle, again, specialized type of muscle. And your epicardium, which is made up of mesenterium, also known as the visceral layer of the serous pericardium. Okay? Sayura, memorize na layers of the heart? Okay, now this one is again what makes the heart unique. Did you even bother to say, okay, heart, itagin mong heart, right? It could anything from an animal or when you, who has really seen a heart? Brennan. Can I aqua heart of human? Okay. You know that if you look at it, it's all muscle. You know, because it's a pumping organ. It's all muscle. It's not true. It has a skeleton. You will be surprised that they bukok ang heart do. Okay, but take note, the word here is fibrous skeleton, which is only found in the heart. Okay. Now this fibroskeleton is shaped in such a way that again you cannot separate it from the heart because it is within. Muna siya built in with the heart and every structure there in the chambers and valves, whatever. Because of this fibroskeleton. And this is its definition. Take note that it is made up of collagen. So it should be cartilaginous, right? Dili siya heavy, dili siya it should not be heavy. So it should be collagenous. And take note that you have two parts. You have the membranous part and you have the muscular part. The muscular part is the feature that frames the four, especially on the side of the septums, that forms the septum of the heart, interventricular and interatrial. Well, the membranous part comprises the figure or the attachment for the valves. Okay, so again, uniqueness of the heart. No? Okay, anyway, before we give you an illustration of the fibroskeleton, these are yet some of the functions why the heart has its own fibroskeleton. Number one, it maintains the patency of the valves. Without the fibroskeleton, ang valves will collapse. Okay? It forms a annulus or ring for the valves to remain in place, both for the semilunar and both for the atrioventricular. Oh, by the way, guys, when we reach the semilunar, you might be confused because these are all still valves. AV, when you hear the word AV, shortcut, I am referring to the mentioned metatarsic tricuspid, okay, or mitral tricuspid, okay? When you hear the word AV valves, these are the mitral and tricuspid, okay? When you hear the word SL valves or semilunar valves, I am referring to the pulmonic valve, which is actually the opening towards the pulmonary trunk, towards the lungs pa. Pulmonary trunk na kay valve diha to control again blood flow. That is your semilunar, and the other one is the aortic valve, which is from the LV. So you have also valves there, but it's not as complicated as the AV valve, but it is still considered that one. Okay? So, attachments for the leaflets and the cups, mo is spelling si CASPA, the cups. Then also for the muscular part, it serves as the attachment for the myocardium, which actually forms ventricular myocardial band. And for me, well, besides number one, which is also very, very important as far as structure, here comes the number 4. Again, so unique because of the membranous part, the fibroskeleton acts as an insulator. Without the fibroskeleton, a heart will just electrocute it by itself. Because again, it has electrical impulse because of the SNO. So the fibroskeleton also acts at the same time as an insulator. I mean, you try to imagine, it's the only it's the only organ besides the brain, na impulse, but we're talking about electrical, coming from the pacemaker, which is the SA node, and the AV node. Don't you know that the heart's muscles actually has built-in branches, which are also conduction pathway, nerve na siya, or electrical impulse, because you need electrical impulse to start pumping the heart. Okay? Pump na siya, you need an electrical impulse. So again, you try to imagine inherent, natural. You have to get electrocuted because it's still electrical. But because of this, it acts as an insulator. The whole thing, the fibroskeleton. Now, if you remove the whole heart, by the way, the heart also, or the fibroskeleton also forms the grooves. For the AV valves, so meaning that's what we call atrioventricular groove, and the other one also is the anterior and posterior interventricular groove. When you see your specimens of the heart, you can see these demarcations. These are clear demarcations between the atria and the ventricles, and between the two ventricles and the two atria. You can see some cleavage there. Now, this cleavage is actually formed by the fibroskeleton, especially the muscular part. Okay, you can never miss that. Now, try to imagine that you have the ability to remove all the portions of the heart. This is how the fibroskeleton looks like. Okay? And I hope you will not approach sila ni Archie and Joshua 2 weeks from now sa laboratory. Magpuang itong fibroskeleton. Ay mo, pag binuang niya, because I think the skeleton man na yung separate specimen. There is no such thing, because again, it is built in sa heart. You cannot separate them. It is what also makes up the heart. So you have to take a look at the heart and look at the other structures. Again, for gross and for illustrations, theoretical purposes. This is how the fibroskeleton looks like. So if you take note, you have the annulus, the rings, which forms or gives support to the atrioventricular valves. This is made up of membranos, while the ones that are here make up the muscular part. This is the interventricular area. That is the intra-atria or inter-atria. Okay? So that is how it actually looks like. You can search other pictures about the fibroskeleton of the heart. Now take note, you have to complete the term fibroskeleton of the heart. Okay, so if you remove, within the heart, and then you take away the fibroskeleton, you separate, that is how you correlate it with what makes up that particular structure of the heart based on the skeleton. Okay. Now, looking at it from superior, or from the cephalad direction, you can actually visualize all the four valves. I was referring to the two AV valves and the two SL valves. You can see all of the valves. If you look at your heart, move all the great vessels and then look at the internal valve. So those are the valves. This plays also a very important part. Now take note that you can see this ring surrounding the valves. That is still part of the fibroskeleton. Okay? Dealing na siya individual. Annulus, we call that annulus, but you can still see this one. Forming the structures so as not to let the cusp or the valve collapse. Okay? Okay, now before we even go into the details of the structures within the chambers of the heart, for added memorization, you need to know that there are boundaries, that there are surfaces of the heart. Now take note again, once you finish memorizing all these surfaces and your borders, you will know now that our heart in our chest, in the central compartment, is not that way. It's not that way. It lies down. Okay? So atong position sa heart actually it lies down, then facing more outside. Meaning ang apex. If you look at the apex of the heart, which comprise the left ventricle, it's more here. And that's is the reason why we have such thing as the apex beat or apical beat. So when you feel and you hear in the fifth intercostal space na ating beat diha. Kuha mo, you better have yourselves check. Maka-feel that? Actually, you can either listen or feel or palpate. That's a thrill. No? Maka-feel ka sa beat, you are now feeling your inferolateral aspect of the left ventricle. That is part of the surface marking. So now the position of our heart is lying down, meaning more on the right ventricle, and yung aphasia na. Okay? And yung mong na-feel na rin is the left ventricle. Kana siya. So, dili na siya straight up. Now, that is at the left fifth intercostal space. It is motionless, but it remains that you can actually feel for the heartbeat. Okay. Once you feel for the apex beat, you are actually feeling also or synchronizing also that it is the time when the mitral valve close. So dealing na siya continuous. If you can feel and listen to the apical beat, mo ng time when the mitral valve close. Meaning, when it closes, nag-fill up na siya. Okay, so you're not supposed to expect na sige na kana imong apical beat. There has to be a time in between. Now, that was the apex of the heart. These are the things that you should memorize because this is also the base of the heart. So, mastahan siya structures. Take note from 1 to 5. So, when you hear the word apex of the heart, moto, LV, inferolateral aspect, when I ask you for the base of the heart, those are the structures that forms the base of the heart. Okay? LA, even the vertebra T6 to T9, all the way to the bifurcation of the PT, then also the PVs, entering the LA, one shaped piece. That line. Okay. Then we go to the surfaces. Okay, surfaces of the heart. Surface anterior, also known as sternocostal. And I want you guys to know what particular structure of the heart correlates with it. Huh? Okay, give me the 4 surfaces of the heart. Give me the structure that forms that particular surface. So, very nice for a multiple choice question. Which of the following forms the sternocostal surface of the heart? Okay? You don't need to read this, you can see it. So you have 4, diaphragmatic, right pulmonary. Do not confuse, you will be confused, honey. That doesn't mean that if your surface is right pulmonary, pulmonary sa mukha. So if I say right pulmonary surface, it's supposed to be the RA. If it's left pulmonary surface, it's supposed to be LV. So you are not LA. Again, because of the position of the heart. Okay? Dili mo siya anak. So take note again, do not, and this number 4 actually correlates with that portion of the left lung. Left pulmonary surface corresponds to the LV of the heart, and that is this particular area also forms the cardiac impression of the left lung. Did you mention about the cardiac impression? Okay, naana siya sa lungs. If you see your left lung, you can see a very deep area there. Murag loud siya, especially the inferior lobe. You can see a demarcation na murag siya smooth na murag cavity. Because that is where the left ventricle lies. So there is still a close correlation with the left ventricle with the inferior lobe of the left lung. Okay? Memorize that. Surface of the heart. Okay. That is anterior, posterior. Ano yung mga vessels? Borders. So do not confuse the surface, from the border. Huh? Okay? Border, R right, RA, inferior border, RV, left border, LV, superior border, again, take off of the great vessels. Mura-mura siya, base, right? Base of the heart. And what comprise the number, the superior border usually comprise the base of the heart. If you look at the mga structures. Okay, borders. We already talked about this one. Pulmonary tract, just to give you an idea of the size or the length or the dimensions of the pulmonary tract is about 5 by 3 centimeters. RV, right and left pulmonary artery, we already know this, master na ninyo when we were reviewing the cardiac cycle. Okay, what is the mga borders? Easy naman kayo inferior. Just give me again, I am not interested in the borders, give me the structure that forms that particular area. Meaning either the border or the surface. Okay, what is this kid doing here? Don't you know that we were talking about the normal placement of the heart, right? But we have such cases, or have you heard of cases which we call dextrocardia? Meaning if you take an X-ray, balik. Balik. And the only way we can take this up is usually incidental. Patient came in for another problem. Then when you listen to the fifth intercostal, I cannot feel a heartbeat. Pero ang bata kang isi-isi ni mo. Uy, man may heart. Turn out to be balik. Okay? It's not common. It's not also rare. So, naana siya sa loob. No? Okay, so balik yung one. Again guys, meaning if you look at it, if the heart is interchanged to the right, also the vessels. Okay, the turn lang na siya. But again, most of these patients are asymptomatic. They live a normal life. And you will be surprised that I think last month ago, we had a patient, young male, 33 years old, came in for appendicitis. When my resident opened up, he was surprised that the appendix was on the other side. And then balik yan tinahin. So we took an X-ray, hasta yung heart. So when you have these conditions wherein the abdominal organs are also inverted, plus the heart, we call it situs inversus. Okay? But if you look at it, the patient was fine. They live a normal life. Bali lang. No? So if you cannot feel for your apical heartbeat, try to feel it on the right. Okay? Tingalin ang may dextrocardia. Don't worry, that makes you unique. It's embryological. Okay, so you don't have to worry about the thing. It's just so happen na pag-form ng pag-embryology and yung liver nasa left. But anyway, sige lang. So, okay. Let's go to the main point of the point. I want you guys to memorize all the structures that are found in each chamber. This is gross anatomy. And the most number of structures that you can see is the first chamber. It's always the RA. Why is it that most of these structures are usually found in the RA? If you notice, there are some terms there which are embryological. Correct? Embryological ba? And these are not functioning anymore. These are not used anymore, but they leave behind remnants that you can still see. If we can still see it, then you need to identify it. So, we start with what we call, this is function. I'll take note again. I mentioned that you have 3 holes in the RA. SVC, IVC, and there's one. This one. This is where all the cardiac veins drain. So meaning, cardiac veins drain everything. Goes to the coronary sinus, which is found in the posterior part of the atrioventricular groove. then everything drains to the right atrium. So you need to identify 3 holes there to start with. You have the pouch, which is an accessory muscle known as the auricle. Now take note, do not interchange auricle from atria, or atrium. It's different. The auricle actually is an appendage. Its purpose is to increase the surface area of the right atrium in case that there is too much filling of that particular area. So do not interchange between the two. Everything falls behind under the atrium. It's part of the atrium. Now, you have a sinus venarum. This is its description. Anything that is posterior, shiny, smooth, anything that occupies the RA at the posterior area is known as your sinus venarum. It's a space. When you hear the word sinus, it's a space. Then you have the anterior portion. You have to open the right atrium. Then you see the anterior surface, which is made up of rough area. And this rough area is known as your musculopectinate. Kung di mo gusto Latin, then you go to the English, which is pectinate muscles. Okay? But I prefer you guys to talk Latin. Hindi paminawan ng Latin. Okay? So, musculopectinate. So, if you answer that in the practical exams, times 2. Pectinate muscles, only 0.5. Okay. Rough muscular anterior part, then at the same time, there is a demarcation or a groove between the anterior rough surface from the sinus venarum. That is the terminal crest or crista terminalis. Demarcation na siya. Again, everything you can see in the heart. Then of course, on top of this sulcus terminalis is the crest. Groove, sulcus. On top of that, na actually line gamay, that is your crista terminalis. So these are the structures that you need to memorize and also the structures that you need to identify in the laboratory. The good news is everything can be seen. Still. Okay? Can still be seen. Now take note, I already mentioned to you about the why is it that there are a lot of embryologic implants in the right atrium? Well, again, there is a very, very important structure in the right atrium. The main reason is when we are on the gestational age, the right atrium is the first chamber of the heart to form. Okay? Then, what comes after next? Embryologically. Once mo form, what chamber mo come after next sa right atrium? The form. Yes? So meaning, kung form ang RA, then RV, then half at the heart. So where does it go to the lungs? Yan, wala siya balikan. Well, anyway, actually the first to form are the 2 atriums. Right? RA, LA. Okay? Later na ang ventricles. And that's the reason why, embryologically, okay, where do they enter? Naate opening between the 2 atrium. And this is known as the fossa ovale. So blood coming to the right goes to the left, to the lungs, balik siya. Okay? Now take note that the lungs in gestational sa neonates or third trimester is not yet developed. Everything goes to the heart lung chamber. So there's an opening there. Now once the ventricles form, this opening or the foramen ovale closes automatically once the ventricles are formed, because blood will go down as a ventricle. So wala siya shunt. This is what we call the shunting. Okay? Now everything, if you have a hole in the atrium between RA and LA, what do you expect? Blood always comes from the left to the right, not right to the left, because of the pressure. Diba? Left has a higher pressure, so left, right goes. Now, you have heard of congenital heart problems. Pediatrics, you heard of the shunts. Atrial septal defect or ASD. This is the reason why. Wag mo close ang iyang uban. Okay? What happens to the child? Every time he cries or she cries, mulagom. Because blood is not enough, can he shut away man. That does not go to the lungs. Instead of the child exert an effort, ang blood, instead of going to the lungs, shunt siya sa right side. So most of the blood that mix niya, siyang blood, is unoxygenated. Okay? Even though they will reach a normal life, but they cannot, endure in sports activities, di siya layo because of the blood mixture. Heart surgeons will only place, they do a septostomy. They don't need to close it with their open heart, but they just place a balloon to plug that hole. It's called a septostomy, if there's a septostomy. That the balloon will there remain for life. Okay, hindi na siya yun. Anyway, SVC, take note that the SVC, again, part of your auscultation surface marking, the area of the SVC correlates with the right third costal cartilage. So if you can palpate your right costal cartilage, more I said, 2, 3, okay, more or less. Okay, third costal cartilage, not rib, costal cartilage. That is where your SVC is. Entrance point of your SVC. So karang kabantay mo nakalagay yung SVC. Then, if you go down further, your IVC is 2 costal cartilages lower. 5th. So, meaning if this is your third, my SVC is 5th. That is where my IVC enters. So if you look at it, our heart is all the way up here, right? All the way up here. So meaning na SVC here, my IVC is here. So meaning if you look at it, my right ventricle, my right side border of the heart is way up here. Okay, now opening cardiac veins. We already mentioned about the coronary sinus. Then you have the interatrial septum. You can never miss this one. It's a thick muscle between the two atriums, and this is the one what I was talking about. Now, depression. You can see that big cavity there in the RA. You call it fossa ovale. You don't call it foramen ovale. But that is the English term. But some books will accept it. It's supposed to be a term wherein we use it, it remains there. But you have to answer it as fossa ovale or oval fossa. You will never miss that one. And if it remains open, that is the atrial septal defect. So it's supposed to close. But depending size of the opening. There are others which is so minimal. Now take note, plantasa, mga structures, RA. That is the sinus spinarum. That is the posterior surface which is considered smooth. You have the sulcus terminalis. That are your pectinate muscles. You can only see the pectinate muscles in the anterior wall of the RA. The one above the pectinate muscles is the crista terminalis. Then you can see the 3 openings there. The smallest, of course, is considered as the coronary sinus. The 2 big ones are the vena cava, up and up. The sinus is way up in between the vena cavas. Okay? So, mo na siyang imong identify sa laboratory. Of course, do not forget the vertical part, for example. Okay? So, do not confuse the sinus vena. Of course, we already talked about the fossa ovale. You can never miss this one, guys. And 99% is will come out in the practical exam. Kana yung fossa ovale. Ha? So, you need to look for that one. I'm very fond of these structures RA. Again, as I mentioned, most of the structures are found in the RA. One especially, okay? So you need to identify the RA, RV. So first of all, before you identify such a structure, you should identify first what chamber are you looking at. Dili na siya tagan-tagan. You should identify what chamber are you looking at. It's just like the lungs. When you start identifying a part or a bronchopulmonary segment, the first thing that you should know is what lung is this, right or left? Then when you automatically know it's right, then you narrow down the bronchopulmonary, although some of them have the same names, right? Well, except for the lingula. the lingular segment, which after the superior inferior lingula from the superior lobe. The rest are practically nine the same name, right? But it's just the location because the shape of the right lung is different from the left lung. Example na siya. Okay, RV. Largest, considered as the largest based on, is the largest part of the biggest of all the chambers. This is what comprises the anterior surface or the sternocostal surface. Also the entire inferior border of the heart. At the top, you have the conus arteriosus. Now, when I say conus arteriosus, this is the area before reaching the pulmonic valve. This is the pulmonic valve, semilunar. Surrounding the pulmonic valve is known as the conus arteriosus. Or very plain and simple, some of them call them infundibulum of the pulmonary tract. Okay? Then you have the trabeculae carneae. Take note of the spelling. It's not carne. It's carneae. You're supposed to pronounce it as carneae. Take note that there's an E before the A. Not A-E. Carneae. Carneae. Trabeculae carneae. Whether you like it or not, that's the English term, so I cannot have to replace it. And these are its definition because there is also a trabeculae carneae in the left ventricle. But the size and shape of the carneae is different depending on the chamber. Then you have the supraventricular crest. That is its description. Okay. RV na siya. RV. Ano mo discuss na. Okay. Tricuspid. Where do you locate for the tricuspid valve? Fourth to the fifth intercostal space. This time is the space. Fourth and fifth intercostal space. Nari ang tricuspid. So if you're looking at it, nari ang spermiditama, nari ang tricuspid, meaning higda kita na itong heart. Right? It's not going up here. So it's lying down. Ganun ang heart. So anyway, valve. Then you have the chordate tendinae. Take note again of the E. So duha na. Trabeculae carneae and your chordate tendinae. Ninananabuhan ako nung ini. Pero okay na kung tendinous cords. Pero only 0.5. Chordate tendinae plus times 2. Mas challenging mga ganyan, di ba? Okay. The question is, you have to identify if you are right. So naatay synonyms with the chordate tendinous cords. Spell chordate tendinae. Pwede ba daw chordate tendinous cords? Okay na. Now, take note again. The chordae has three areas. These are the things that you should memorize. Now, take note. Remember, tricuspid. We are talking about the right ventricle. So you're going to expect three cusps. Correct? Tulong may valves, right? So each valve has to have each cusp, each chordae, each papillary muscle. Tulong na siya. It's like a parachute. Because we're going to go to the left, duha siya. But they have specific names. Anterior, posterior, septal. The location itself is understandable. Anterior, which is supposed to be the biggest. The posterior and the septal. When you hear the word septal, the cord is coming from the interventricular septum. Septal. Get the word? Interseptum siya coming out. So it should be interseptal. So 3. Expect 3 anterior posterior septal. Okay? Now take note that these are all connected to what we call the papillary muscles. Take note of the description for each. As I mentioned, the anterior is the biggest and the thickest. Posterior, and where is it connected? And the septal. Now, kindly read the description. What is in the description? The cord, focus on the anterior papillary. The cord is attached to both anterior and posterior. The posterior, the cords are attached posterior to septal. Gets mo? Okay? So one papillary muscle, one cord is attached to both cusp, meaning the anterior and posterior. The posterior papillary muscle, to include the cord, is connected to the posterior and septal cusp. While the septal is connected to septal and anterior. So, unsa may nasuot yung una-una? So, wrong. Daghan naging memorize doon. Okay, meaning, if a papillary muscle contracts and brings down the valve, connected ba siya? Take note, papillary muscle, tendinous cords, cusp, which makes up the valve. So if one papillary muscle is connected to two cusps, depende, anterior, posterior, septal, when the valve closes, it turns, and when it opens, turns back. We were made to believe that the valve open, close, open, high, open, close. It turns. So when the valve closes, tuyok, open, because it is connected to two cusps ang pusat, papillary muscle. So when it contracts, ana siya. Okay? The same with the other one. But again, this is only applicable for the triangle. Understandable. So, ikuha naman siya. So, ana siya. Right? So, ana yan mag-close. So, if you try to remember now, when our valve closes, because when there is feeling from blood, RARV, ana yan closure sa valve. Okay, it's like, it's supposed to be burned. Okay? Because of this very peculiar connections. At the same time, when you have a closure which is shaped like that, it is more efficient in not actually rejecting blood backwards compared to open close. Correct? You're not supposed to have blood from the RV going back to the RA. You're not supposed to have that. Meaning, that's where valve problem comes in. And that is what we call, regurgitation. Panic. And that's the reason. The only imaging that you need to have this is when you do a tip to the echo. Okay? But again, most of the patients will have symptoms. Bumalik ko ng imong blood. Okay? So you're going to have symptoms like syncope, faintness, ay mo pag faint na yun ng exam. Look, I have regurgitation. Regurgitation, so mataputo na. Okay? Okay. RV. This is the thickest portion. Interventricular. Again, you cannot miss this one. It's so thick. Okay? Both muscular and membranous. Strong oblique muscular part is bigger than the membranous part. Then you have this one. This is my favorite tappable item. Gusto mo yung ganito favorite? Ano mo ba? Okay, that is what we call the moderator band. But if you answer septomarginal trabecula, that is times 2. So moderator band, only one. English term. Okay, septomarginal trabecula. That is a band that you can see in the RV, which you can see coming out from the interventricular septum heading towards the base of the anterior papillary muscle. You can never miss this one. Yan direction is like that. It's at the base of the anterior papillary muscle. Why is this guy so important? Because this is where the right bundle branch coming from the interventricular septum pass through. Take note that the anterior papillary muscle is the most important papillary muscle in the RV. So meaning it has to have its own branch nerve conduction. It triggers the anterior papillary muscle to open up and close the valve so that the blood will be injected further going towards the pulmonary tract. Okay? Take note again, conus arteriosus is somewhere around the left third costal cartilage based on surface markings. Kaniha, ano description ha? It can come out in the theory or it can come out in the practice. I'm going to give you a lot of choices, and I'm going to use Latin terms, and I'm going to use English terms, okay? The following is the one carrying the right bundle branch example. Which of the following? Bigyan ko was. Okay, so take note. Anterior. Let's focus on the papillary muscles. Anterior, posterior, Arvinia. Then you have the septal. Okay? You have the septal here. Not a good illustration. I'll show you another one. You have the chordae tendineae. You have the cusp. So it's like a parachute if you look at it, di ba? Papillary, chordae tendineae, cusp, which forms the three of them, which forms the whole thing, is the atrioventricular or the tricuspid valve. Then you have the trabeculae carneae. Do not confuse the trabeculae carneae with the chordae tendineae. Ha? Although namaka-EA, but again, the trabeculae carneae is the one that make up the muscular portion of the RV. Kana sila. Okay, these are finger-like projections compared to the chordae tendineae, which is the cord. Think of a parachute na that one. Now, this one is the one I was referring. That is your septo-marginal trabeculae. Some heart specimens are very clear, some heart specimens are not. But if you can see, do not mistake the moderator from the septal papillary muscle. Very obvious. If you mistake them as your septal papillary muscle, if there is no cord, then it's not supposed to be a papillary muscle. Complete set gina siya. If you buy it, you have to have everything. So if you see a papillary muscle, cord, cusp. If you see a structure heading towards the papillary, definitely it should not be your papillary. It should be your septomarginal. And there is only one there that you see. The direction is like that. Going down. Okay? Clearer one will be this one. Okay, so for papillary muscles, you have the anterior, you have the septal. Septal meaning coming from the IVS, interventricular septum, and you have the chordae and you have your cusp. Okay? Now, take note that that is your moderator mark. Kahigda na siya, but it do not, again, it's distinct from the trabeculae carneae because it's more superficial. So more superficial. The trabeculae actually is embedded in the wall of the RV. Okay? Okay, I just mentioned about the ASD, shortcut acroseptal defect. Definitely for the fossa ovale, it remains patent. Okay, so left to right shunting. Still part of the congenital heart. It's quite common, guys. Take note. It's 25% of population of ASDs. So for some of you who are very if you want to engage in sports and then all of a sudden you become kapoy. Actually, you cannot see this in X-ray. You need a 2D echo to tell it. If you have ASD, some of them have very small holes. You can live a normal life, but you have a very, very small hole there. But when you exert effort, you still need. You will get fatigued easily. Okay. We don't want to drag. I never had. I had a 2D echo once. Okay, LA. Let's go to the LA. Okay, the best part of LA is it's probably the chamber of the heart that has the fewest structures that you need to identify. Okay. Forms most of the base, if you try to recall that illustration. The only structures that you need to see inside are the pulmonary veins. Okay? 2 above, 2 below. Superior, inferior. Then you have still also the auricle, the left auricle, just like the right, but the left auricle is a little bit smaller compared to the right. Then this is its description, and this is its definition of the LA. Larger, smooth walled, slightly thicker, blah, blah, blah. What makes up for the left atrium as far as anatomical structures? More again yung pangita, okay? There you can still see a portion, a little bit part of the foramen ovale. of course, the biggest part, connected ba sila? So the biggest part you see is in the RA. You can still see a small depression there, which is still considered part of the Fossa Valley, but it will be, to be fair, we need to tag the one on the right atrium because it's much. Okay? So definitely the things that you need just to identify here are the pulmonary veins. There are 4 of them. All of them entering the LA. Okay? But unfortunately, what makes up from anatomy based on the number of structures that is seen in the LA makes up for the clinical side. Because thrombus or embolus, which is the main source of cases for strokes, or what we call the medical term, the cerebrovascular accidents, the source is all coming from the LA. So, nabawi siya sa anatomy, which mayroon ang identifiable structures, as far as clinical source studies have shown that most of the thrombus comes from the LA source. Okay? So meaning, why is it that way? Meaning you can see now that blood coming from both lungs goes to the LA. You have to remember that this is both lungs. So, ang blood pump is so, ang pressure is so high that it goes there. So, for example, if you have a clot that circulated from down, you will be surprised that the clots or thrombus are all coming from the lower extremities. But the flow is so fast that when it goes to the right side, it goes to the lungs, oxygenates, and then both of them goes together to the left atrium. No time to lyse that clot, then that is the source there. And sometimes the problem is most of these clots stay in the LA, undetected. So when they dislodge, they go to the LV, goes to the aorta. And because of the pressure, remember, ascending, it's either towards the heart, via the coronary arteries, so mga heart attacks, maklat ang coronary, or maka-escape siya sa coronary, goes up, ascending, goes to the arc of the aorta, pressure is way up towards the brain, goes to the carotids, which is common carotid, especially the internal, because again, clots follow the pressure, the highest pressure. So 2 things, either goes back to the heart, clot the branch of the coronary artery, heart attack or angina or ischemia, or if it escapes, goes to the ascending arc carotid. So 2 things, either brain, heart itself. Okay, so mo ni ang source kasi kada. Diyan na siya mustambay. LA. Diyan na siya mustambay sa left atrium. Okay? So for the left ventricle, if you take note of the difference between the RV, okay, muna siya ang definition based on the border and the surfaces. So walls are thicker. Take note that the trabeculae carni here are fewer, but more numerous. Okay? Smaller makes up by the number. So they are more numerous compared to the right. They are conical, longer. There are only 2 papillary muscles, anterior, posterior, no more septal. Then they have the aortic vestibule. This is the counterpart of the conus arteriosus on the pulmonic valve. This one is the aortic orifice, aortic valve before going to the ascending aorta. Mitral valve forming the cusp, then aortic. The sad part here is as far as the left ventricle, again, clinical, number 6, is still the most commonly involved valve for replacement. Because of the wear and tear. Because again, blood of the pressure coming from the lungs. I was just talking about pressure, LA. Siya mo isigi, buntakan ng dugo. Higher pressure. So the valve of the mitral is the most abused and the most likely going to be destroyed. Okay? So, but still, the most common culprit for mitral valve replacements, or what we call as the MVP, you heard the MVP, mitral valve prolapse. Meaning, now you can understand them in such a way that the cusp is all reliant on the papillary muscles, correct? Cords connecting to the cusp. So if any of the papillary muscles gets weak, or the cords gets torn, or wear and tear, mulubag ang cusp. So it's supposed to close, but if it becomes lax, ang tendency, move down siya. Move down ba? So it's either close, meaning when they close, it's supposed to close entirely. But when they close and will not open anymore, that is stenosis. Okay? And of course, if it opens or if it closes but leaves a gap still for blood to come back or go back, that is regurgitation. Stenosis, relaxed regurgitation. Whether you cannot help anything but you need to replace the valve. You need to replace it. And you cannot buy it in Shopee. Most common still culprit is rheumatic heart. I used to know a pointer from Manila now. He has to replace his valve every 10 years. Rheumatic heart, every 10 years. So that's how low na ka na siya. Now, again, what do they use for the valve? Big sleeve. It's again big valve. Papoy ako, uli lihat. Okay, so every 10 years of kanahan. So try to imagine lang ang ato as we grow older, the wear and tear of these things. So sometimes it's inherent, sometimes it's acquired. Acquired meaning, what do you call that, acquired? Sometimes, and the good news here is have it checked. You can actually identify your valves, whether they're in good function or not. Once symptoms start, it may be too late. Okay, so now you have already known the different classifications for the different heart ailments. When you talk about valves, then you say cardiac valve problems, okay, or acquired valve problems. So when you hear the word valve problems sa cardiac, medical term for heart is cardiac. You are referring to the atrioventricular valves. These are the ones that are usually commonly involved. But there are cases wherein the semilunar valves may also be destroyed. Okay, so valve problems, you have congenital based on the ASD and the VSD, and also you have the acquired. You also have what we have never been touching past coronary, which is actually the most common cause of death. Not the valve, not congenital, it's the blood supply. That's the most commonly cause of death worldwide, which is the coronary heart disease. Dahil na siya classification. So yung congenital heart disease, valvular heart disease. So when you hear coronary, kung siyang blood supply. Okay, and I just give you one example. Katapit ang clot, then go sa coronary, then blood. Any branch, depende sa branch. So that can involve causes based on clinical. Okay, so LV, muna ang shape sa atong papillary muscle, anterior and posterior, and the papillary carne is not as complicated compared sa RD. Okay, so in other words, most of the structures that you need to identify are usually found in the right side. Mitral valve, tukas, anterior posterior, you usually identify them surface marking at the fourth costal cartilage. Cords, more than one muscle. So meaning, the point here is the papillary muscle anterior is still connected to the posterior, while the posterior cord is still connected to the anterior. Dili siya one-on-one. Okay, they're not separate. They are still connected with both. When they open and close, but again, there are only two capsules, not the one I mentioned, the semicircular. Then the aortic valve between the LV and the ascending aorta around the area of the left third ICS. Now take note guys, I have been mentioning in passing the surface markings, Naimagawas na ha? I did not identify it. Why did I have to mention it? For decoration. So when I mentioned the surface marking, because it still plays a very important role. Okay? So when I say, what is the area that you can know but between the area of the left third ICS? So the answer should be aortic valve. What? na nisin sila. Sorry daw ako kagat. So yun na lang, okay, but anything that should be mentioned here should be known. Okay, so we have been touching now already the chambers. We finished the AV valves. Now let's focus on the last two here. Okay? The SL valves. They are not as complicated as the AV valves. But take note, pulmonic. Let's start with the pulmonary. Pulmonary or the pulmonary tract coming from the RV. Focus na. There are three semi-lunar cusps. And they are namely identified as anterior, right, left. There's a difference now. Okay? Anterior, right, and left. Weird. Because again, in this direction, if you're looking at it from above. Then you have the aortic valve. Now this time it's posterior, still right and left. So in other words, each valve, pulmonic and aortic, has three cusps. But they do not have cords. Okay? They do not have cords. Sorry. For the aortic valve, again, all of them, now take note that this pulmonary valve and aortic valve, cunning description here applies to both of them. Okay, so if you notice that this description here, or definitions, is not just for the aortic. So both for the, as a whole, those are its general descriptions. And no, both of them do not have cords. They're smaller. The exertion here is lesser compared to the AV valves. Thickened edges, just take note of the two areas. When there is the flap or the cusp, when they get in touch with each other, we call them lunule. And at the apex of those three contact areas, we call them nodule. Okay, so those are just the things that you need to memorize. Now, there are of course some important branches coming from the aortic valve. So we need to mention them again for purposes. Of course, you still have the sinus. So if you see above, you see a dilated portion prior to the vein or prior to the vessel, then those are what we call sinuses, and they have a purpose. The main reason is to avoid the cusp because they don't have cords. So they have sinuses to replace the cusp, meaning so that this particular cusp, which are smaller, will not attach with each other, especially to the wall of the vessel. Okay? So automatically na siya yung dilatation. And these are all called sinuses. You have the right, we're talking about the aortic. You have the right aortic sinus, where the right coronary artery comes out, meaning the origin, and the left, which the LCA also comes out. These are all from the sinuses. And of course, you have the posterior, which they do not have a sinus after all. So what is the significance of this? Okay, imagine aortic, meaning you have the aortic sinus. Right side, you have the takeoff of the right coronary artery towards the heart. Then also the left one is the left coronary artery. So what does this mean? If you notice, blood from the LV coming from the lungs, LV, goes to the aortic valve. First branch, right coronary, left coronary, before it becomes the ascending aorta. Again, the beauty of nature tells you that the freshest blood, first branch, goes back to the heart. Tama? Meaning, the first branch of the aorta is not the subclavian. It's not the common carotid. It's the coronaries. So when blood palang gikan sa left ventricle goes outside towards the rest of the systemic circulation, it already gives out blood, the freshest one, to the heart itself. But again, there is also the disadvantage, meaning the one that I mentioned a little while ago. If there is a clot, if there is an embolus, it's the first one to get the clot too. You see that one? So if you have the clot, una sa siya affected branch. It's a good thing that there's no clot, fine, if it's normal. Or if the clot or the thrombus is so small that it actually just goes out, passes through. But if there's a clot, there's a clot. It eventually ends up somewhere. And the most common culprit is still the right coronary artery. Okay? It's still the right coronary artery, the main branch, which most of the clot goes to. So it usually affects the right side of the heart. So that is the clinical importance of why there is that reason. Okay, so if you get to be asked a question, what is the first branch of the aorta or from the aortic valve, you should answer coronaries. There's a difference when I ask what is the first branch from the arc of the aorta, very specific, then you answer the rest. The common mentioned, the subclavians, the common carotids, and the brachiocephalic. But again, depende na siya sa source of question. Okay? Okay, so again, looking at it. Now, this one is the pulmonic. Take note that that is anterior based on its location. So you have the three cusps in general. So if this is the pulmonic, you have the anterior, right, left. If this is the aortic, that should be the posterior. Then you have the right and the left. But take note that there are the branches coming out the coronary artery. And the sinus dilatation is only found in the aortic. There is no sinus in the pulmonic. Okay? Okay, here's a review of everything. So, more or less, I think that's about Padona naman. If you know. It's still 11:30. If you notice again, at the end of the chop of the heart, the pericardium, you will be surprised that again the wonder of the heart. Diba? The beauty, the direction. It's not a simple chamber where you really need to believe that. Why is it, okay, going back to the remnants, why do you need to have the trabecular carne in the first place? Trabecular carne, which is the rough edges found in both right and left ventricle. Again, everything has its purpose, and that's the beauty in medicine. Basic knowledge is not even an excuse. There is always an answer. Why are these structures there? Except for the RA, which are usually in embryologic remnants. Now, the trabecular carne's purpose there is to again increase the surface area. The more rough ang imong area, the more you can fill up as far as air or fluid, right? And you don't want your heart to increase in size because there is always a limit. For example, if there is a problem with the filling of RA because there's too much blood going in, and by the way, there's a problem with the control or the conduction, and it starts to fill up the blood on the right before it gets ejected, it increases the surface area about times 2 or times 3. Now take note that the trabecular carne in the RV is thicker, although they're fewer, which is actually compensated by the trabecular carne on the LV, which is which is smaller, but more numerous. So they compensate less with each other. Okay? So there's always an answer. So to everything, even anatomy is not even excuse. Okay, I like, okay. Some of the valvular heart disease, some of them are already mentioned. At least you will have an idea when you hear such terms and what is it all about. So when you hear VHD, when you hear stenosis, it's failure to open full. Open gapon siya, pero not open. So medyo na siya opening. That's called stenosis, not the other way around. Then you have insufficiency or dilatation, baliktad. Failure to close completely. Okay? Now, all of these terms applies to all the valves, whether atrioventricular or semilunar. You can have pulmonic stenosis, you can have pulmonic regurgitation, and everything. Then you have MVP, I already mentioned this one, pulmonary vein incompetence, aortic valve stenosis, rheumatic heart, and degenerative. Now, this is more atherosclerosis. Okay, more common in elderly, this is common in younger generation. Okay? So that's the here, when you have rheumatic heart and when you have a mitral valve prolapse, secondary to rheumatic heart, we call it rheumatic heart disease. Huh? So you change the definition of our diagnosis. So if there is a concomitant MVP, secondary to rheumatic heart, then you say RHD. So you just say rheumatic heart disease. Okay, so again, the difference between prolapse and okay, now I like to show you an X-ray. Can I go back to an X-ray? You know, we have this. I did only has only 10 minutes. This is very important to me. Not this one, but that. Where was that diffusion? Or was it in the other one? Yeah, not confused mo. Okay, get it done. Give me 2 minutes. I'll go back to that pericardium.